Good afternoon, everyone. Welcome to my presentation. My name is Flóra, Olasz, and my PhD is about the complex therapy for children with unilateral cleft lip and palate. Let me introduce myself a bit further. I'm a second-year orthodontist resident and a first-year PhD student. I work at the Department of Pediatric Dentistry and Orthodontics, which gave me the great opportunity to work with children who has different syndromes and congenital anomalies. And that leads me to my mission, which is to create a gold standard for unilateral cleft lip and palate patients. And I like to achieve that through researching existing techniques and comparing them. As I mentioned before, I do want to look into complex therapy for these children who have these different and very specific congenital anomaly. And I do think it's important not to just look at one specific time frame, but to go through different time frames since it affects them from day one till later ages. That leads me to my first clinical question, or my first project, which is investigating the effectiveness of presurgical therapy possibilities for unilateral cleft lip and palate in infants. And this stage involves from their birth, so day one, until the first cleft closing surgery, which is around 3 or 6 months of age. As far as I'm aware, we're all working medical fields. Some of us are already parents, some of us willing to or wanting to be parents one day, so I'm hoping we all hope to have children that are very happy, healthy, and don't have to go very specific problems in their early ages, but however, unfortunately, cleft lip and palate is one of the most common congenital anomalies that is affecting the craniofacial region. Out of 800 babies, 1 is born with this anomaly, and the etiology is still researched to this very day, but we know that genetic factors and environmental factors are playing a big role in it. The malformation usually occurs in utero in the first 5 to 12 weeks when the palatal shell fuses gets distribution. And it easily requires impaired functions such as breathing, swallowing, proper breastfeeding, which leads to improper malnutrition, as well as the lesser development throughout the early days of these babies. This is where our role comes in as orthodontists, because we like to or want to help navigate them through the field of surgery. And first we meet them and when they're around 12 weeks old, and this is when we take impressions, which happens to be done to casts, and then we provide them with a presurgical nasoalveolar molding, which is actually an acrylic infant orthopedics, which you can see in the upper picture. This is the orthopedic placed into mouth, and we usually place it there with a removable appliance glue. And we use also kinesio tape as well, which helps the cleft lip, and we use nasal stents for the nasal aesthetics. We do have follow-ups every 2 to 3 weeks with these babies, where we take out the appliance and then we modify this appliance so we can help manipulate the growth of the maxilla, the alveolar bone, to the proper way. And in between the follow-ups, the parents have to take out the appliance once a day to clean them, but it is in place 24 hours until the surgery. Obviously, having this appliance in their mouth helps them giving back the basic function so they can breastfeed, they can properly breathe, because it closes the gap between the nose and the mouth. So we do think it's an efficient protocol, although there's nothing or not a gold standard in this regarding this treatment, because even in Hungary, there are 2 different centers that do give the therapy and the other ones don't give the therapy. So we'd like to prove that this therapy is efficient, and the way we can do that is having impressions in the beginning and then after the treatment, and choosing specific points in the maxilla and then comparing them. This leads to my clinical question, which is how efficient is the PNOM treatment in unilateral cleft and palate? We use the PICO framework. My population is infants with the UCLP. Intervention would be them getting the treatment. Comparator would be getting no treatment, only the surgery. And the outcome we would like to, as shown before in the other slide, we would like to see the cleft shrinkage on the maxilla. We're looking at 4 points, and then we're going to objectively compare them. This would give us a clinical benefit, which is a beneficial maxillary growth. Our hypothesis is that PNOM treatment is beneficial for these babies. We conducted our systematic search, and on the 26th of November, as you can see, we have quite low data on this topic, which means it should be explored a lot more than what it is right now. Let me introduce my first article. Luckily, there are different centers and countries that take this rather seriously. So in the Netherlands, there are 3 different centers that deal with this issue. They conducted a big randomized control trial, which had large sample size, 49 babies, and it involves 3 cleft centers, and they use the same protocol. The limitations that we're dealing with here is that they're using analog methods, and the last follow-up is at 15 weeks. On the other article, it takes us to another country, and we can see the population of Egypt. They're also using a control trial, which is randomized, which is very good for us, and they're using a lesser size, which is a 34 patients sample size, and they're using student printed, and then the last follow-up is at 12 weeks. But they're all using the same population, they're all introducing the appliance at the same time, and they're using the same outcome for the maxilla points that we need. This is my flowchart. Right now, we're at the number of 7 full texts that we're willing to look into, so hopefully we're going to be able to extract them in the upcoming weeks. And up until now, I've only talked about their first year of life regarding these children, but it's very important to look into the further details, because obviously we don't let their hands go on the first year. We check up on them regularly, and once the teeth come in, either it's milky or permanent, we do have to have like a very close up with them. This leads me to my second topic, which is investigating the prevalence of dental anomalies amongst non-syndromic and syndromic cleft lip and palate patients. It's not just the facial appearance, so nasal or facial asymmetry that we can see with these patients. We can also see the malfunction in their mouth, such as you see the upper one, the premaxillas move to different ways, and it is suggested that the cleft genes produce disturbance in many body tissues. Therefore, also it produces a disturbance in the dental lamina, and that can cause into malformation in the morphology, the size, the position, which can lead into abnormal crown morphology seen on the upper picture, as well as position and place as well. We also know that the area that's affected mostly with the cleft has missing teeth, as well as malformation bites, such as crossbite, which you see in the lower picture. So working with these children, I do see how incredibly endurably they're taking all these doctor visits, the surgeries, the patients that they're dealing with throughout these years, as well as the parents. Also their unbelievable care, so they have their children in attendance, and I think it's the least we can do as orthodontics to help provide a very good protocol for them to help throughout these times and to put it into clinical use. And I'd like to thank you for your attention with a quote from Stephen Hawking, which is the greatest enemy of knowledge is not ignorance, it's the illusion of knowledge. Thank you very much for your attention.
I want to ask, you said the first project, the 2 universities have a disagreement with the treatment.
Yes.
And what do you think after your meta, they change the old protocol for the new one, for your metas? Or what do you think? Because I think it's in the Semmelweis universities quite much better, but what do you think? And thank you.
Not to be specific about the universities that don't do it, but obviously we work very closely with surgeons as well, so it's also their decision how they want to enroll it, and sometimes they have the bigger words in it. For us in Budapest, it is a normal protocol to treat them, and either this comes out as whatever it comes out, we will still be treating them. I'm not too sure the other university, which I'm not naming, is gonna change this protocol, because they're highly believe that what they're doing is just good as what they're doing, unfortunately, but hopefully they will.
Thank you.
Do you have any data about, or are there any specific centers here in Hungary that parents can visit to get this treatment? And if so, how many are there approximately?
Thank you for your question. Actually, there's, as far as we know, we are in Budapest the only official center that provides this care. As I mentioned before, we do work very closely with the surgeons. So first, the surgeons obviously see them and they refer it to us. They can come from all over the country, so it doesn't have to be specifically from Budapest. It can be from anywhere. But unfortunately, you can't go into a private clinic and get this thing done, because obviously it's a bit of a teamwork. So for now, I would say that does the pre-surgical treatment, it's just Budapest.
Thank you so much. And my second question is that, are there any contraindications for this treatment?
Thank you for your question. Yes, there are. First, I would say allergies. So if you have any kind of dermatitis or any kind of allergies to the tape, for instance, then obviously you can't use it because it causes infection. And well as if you're allergic to acrylic or anything like that. And the main reason as well, if they're lacking of compliance, mostly the parents, because then obviously it's just an extra harm to bring the children into the hospital back and forth when they're so young, and they can get infections and anything. So these 3 I would name.
I'd like to ask you, once I noticed the procedure of taking an impression to 3 months baby, it was a disaster. Is that possible? And even using the intraoral scanner, can that insert it and follow a certain pattern inside that patient baby? patient mouth?
Thank you for your question. That's a very good input. Yeah, as for now, we're using analog mode, so we are actually taking impressions, and it is quite a ride. But I'd say, like, in the long run, we would like to switch to oral scan because it's probably easier in that way. Obviously, if they chew on it or anything, it can have its issues from the early age. Sometimes they get teeth to quite an early age, so if we're still developing the system to that, but that would be a great work because also it's good for documentation, better than casts, obviously, even for measurements. Thank you, Freen.
Were you thinking maybe to investigate also a bilateral cleft in addition? And what, can you name, like, a short answer, maybe what is the difference, the main difference between them?
Thank you for your question. To put it shortly, and if we're only looking at PNUM treatment, I do think bilateral is slightly more interesting in my way, just because of the facial ways, since the premaxilla is so protruded in the beginning, and with the taping and the acrylic infant orthopedics, we can kind of retrude it a lot, and it helps with the scarring and it helps with the surgery. But there's way less articles about it, so it's really hard to explore that. That's why we're not involving that for now, but in the long run, I'd love to investigate more in the bilateral as well. Thank you
so much.